Thank you so much. Pleasure to be here again. And I'm now going to talk about something that's iatrogenic. Earlier on, I talked about obesity and the increasing obesity rates. And as a result of that, we've had a lot of bariatric surgery. And because of bariatric surgery, we've now come along with this problem as well. So I don't have any disclosures relevant to this presentation, but what I'd like to do is discuss the clinical presentation of post-bariatric hypoglycemia syndrome, and then review some of the potential mechanisms that underlie PBH, and then elaborate on the practical diagnostic and management strategies. So, as I said, the more surgeries we do, the more likely we are to encounter this in clinical practice. We know that it's increasingly recognized after bariatric surgery, all the different types that are shown on the slide, but also it can occur after other upper gastrointestinal surgeries as well. What about the prevalence? The true frequency is really not known because of the differences in the diagnostic criteria and the lack of patient and physician awareness. So sometimes post-bariatric hypoglycemia may be confused with dumping syndrome, and I'm going to talk about the differences between the two. But from the literature, we know that dumping syndrome occurs more commonly, about 19 to 42% of the patients, whereas post-bariatric hypoglycemia is much less in frequency. So just to point out the differences between these two conditions, dumping syndrome usually occurs immediately after surgery, within the first few weeks to months, whereas post-bariatric hypoglycemia usually a year or much later after surgery. Symptoms in relation to the meal, and therefore, when you're taking a history, it's important to ask about this. In dumping syndrome, it's usually immediately after they start eating, 10 to 30 minutes postprandial, they will start having the gastrointestinal and vasomotor symptoms. Whereas in post-bariatric hypoglycemia, it's usually 1 to 3 hours after the meal. So you're all in a postprandial state now. Symptoms, as I've said, predominantly in dumping syndrome, it's both the vasomotor and gastrointestinal, whereas in PBH, it's mainly hypoglycemic symptoms. The glucose levels typically are normal in dumping syndrome, but they are low in post-bariatric hypoglycemia. And the mechanisms, I'll elaborate more about that with some illustrations. In dumping syndrome, it's thought that there's a rapid delivery of food into the small intestine, and so you've got this rapid osmotic fluid shifts that then may cause both the GI and vasomotor symptoms. Whereas in post-bariatric hypoglycemia, we think it's mainly because of the increased insulin sensitivity and insulin secretion from the beta cells. So, here are sort of the glycemic patterns that we would expect to see. One thing to highlight is the fact that there's usually no fasting hypoglycemia. Patients with PBH don't usually present with fasting hypoglycemia. It's always postprandial. And as you can see here from the graphs, it's usually around 1 to 3 hours after the meal. And you get this roller coaster of spikes where you have postprandial spikes, and then you have a postprandial low, and the patients are always chasing, they will take another glucose load and then end up with another hypoglycemia. So these may occur several times during the day. They may get some nocturnal lows as well, depending on the glucose intake that they had taken before going to sleep, but it's not very common. So what's the appropriate glucose threshold that we use for defining hypoglycemia? It's the same that we do in other forms of hypoglycemia. We use the ADA guidelines, less than 70 as level 1 hypoglycemia, and less than 54 as level 2 hypoglycemia. The Endocrine Society, however, use another threshold. They use less than 55 in those individuals without diabetes. Symptoms, you need to have a Whipple's triad where you have symptoms, low glucose, and then the symptoms are relieved with the intake of glucose, or carbohydrate rather. So who are the sort of patients that are more likely to experience or have this complication? It tends to occur in the younger age group, usually females, and also tends to occur more frequently in those who achieve a greater post-operative weight loss, or those who have a higher insulin sensitivity pre-operatively. So if the hemoglobin A1C before they've had their surgery is on the lowish end, they are the ones who are more likely to experience post-bariatric hypoglycemia. So then what are the potential mechanisms? And here is a nice illustration by Patty and colleagues that looks at what are the sort of plausible mechanisms. So one, we do know that there's a rapid delivery of nutrients to the foregut, and what this does is it causes an increase in the postprandial GLP-1 levels and the other intestinal hormones such as GIP and PYY. That increases the beta cell sensitivity to glucose, and therefore, it causes a higher insulin secretion, and therefore you may get hypoglycemia. On the other hand, we also think that that might be a defective autoregulatory mechanism whereby the cortisol, epinephrine levels, and glucagon levels are also lower than they should be. And then we also have, on the other hand, other factors such as maybe differences in the microbiome, changes in bile acid composition, a reduction in hepatic glucose production, which may all be contributing to this risk of developing post-bariatric hypoglycemia. There might be a genetic predisposition as well. So what about the role of this altered counter-regulation? And here are some graphs that actually show that there is indeed a difference in the cortisol, epinephrine, and glucagon levels. So the dark lines are the ones where it's pre-surgery, and then after you've had the surgery are the dashed lines, and you can see that the glucagon levels are much suppressed, the cortisol levels also lower, epinephrine and norepinephrine levels are lower. So you do get this reduced counter-regulatory response during the hypoglycemic clamp studies, again, telling us that this may be one of the plausible mechanisms that would result in post-bariatric hypoglycemia. What about the pancreas? Is there anything going on in terms of the pancreatic mass? And some studies have shown that there is an increase in the islet size in those with severe post-bariatric hypoglycemia. So in the first panel you have, this is the patients who have not had any surgery, that's the control. I don't know if that, no, does it? No, the pointer doesn't work. And then you have the patients in the middle are the ones who've had a post-bariatric procedure. And then, of course, on the far end, you have the insulinoma, where you can see the really dark staining. Now, beta cell is not a predominant predictor. Why do we think that? Because feeding via a G-tube, and I'll talk about that later on, doesn't actually resolve the excessive GLP-1 and insulin secretion. The acute inhibition of GLP-1 signaling also, we know, improves hypoglycemia. And if you do a partial pancreatectomy, it doesn't actually cure the hypoglycemia. So it's not about the beta cell mass. It's a functional disorder and not an anatomic one. So what are the diagnostic strategies? And this is quite a debilitating condition, and sometimes it may be difficult in the clinic to really work out what is going on. And often I get the patients say, "Doctora, أنا مليت من هذا الهبوط." It's so frustrating. So history is really, really important. When did the symptoms start? That's really crucial. Did the symptoms begin immediately after they had their procedure, or is this happening a year or two after they've had their procedure? What kind of surgery did they have? What is the weight trajectory looking like? So those who have postprandial hypoglycemia will tend to yo-yo. So because obviously they're trying to consume excess carbohydrates in order not to feel the hypo. What is the relation to meals? Again, we said In dumping syndrome, it's usually occurring very early on, whereas post-bariatric hypoglycemia, the patients will usually start feeling those symptoms an hour or two after they've had. Are there any provocative foods? What about nocturnal symptoms? And then also we need to know whether they're having fasting hypoglycemia, because if they're having fasting hypoglycemia, then it's unlikely to be PBH. A record of the food logs and the symptom log may be important as part of your diagnostic strategy. A blinded CGM may also be helpful to show you those glycemic excursions and identify some patterns. CGM is not for diagnosis. It's less accurate, particularly in the hypoglycemia range. So this is a very good algorithm that was put up by the Endocrine Society, and it looks a bit complicated, but I'll walk you through it. So in somebody who presents with adrenergic, cholinergic, or neuroglycopenic symptoms, and the glucose level is less than 70 milligrams per deciliter, that may be, yes, a possible hypoglycemia. You would then confirm that if you've got the test. Is it relieved with carbohydrate? Yes, it is a hypoglycemic. You label that as a hypoglycemic disorder, and then ask the other questions. What is the postprandial pattern like? Is it more than 6 months after surgery? It's likely to be post-bariatric hypoglycemia syndrome, and therefore you may initiate treatment with nutrition, dietary modalities, and acarbose, and I'll talk about the pharmacotherapy. On the other hand, if the patient is getting fasting or nocturnal hypoglycemia, and these symptoms have occurred less than 6 months after they've had the procedure, then this is usually atypical, and you want to consider other hypoglycemic disorders. So then, what other diagnoses should we be considering? Insulinomas, of course, are top on the list. These also can cause postprandial hypoglycemia, but these patients will also have a fasting hypoglycemia. Adrenal insufficiency, autoimmune hypoglycemia, renal and hepatic impairment can also lead to hypoglycemia. The effects of medications, if the patient is still taking their GLP-1 or taking insulin, that might be the cause. And of course, it's also good to know about the amount of alcohol that the patient is consuming. So how do we then provoke, or should we provoke hypoglycemia? If we are to provoke hypoglycemia, then the oral glucose tolerance test is not the best one to be used. It's better to use a mixed meal test, and that is one which of course contains a protein, carbohydrate, and fat. If you're going to do it, then make sure that you've got your crash cart ready for correcting the hypoglycemia, because it may be severe enough for a patient to end up with seizures. So you have to do it in a clinical setting whereby you have all the resuscitative measures around you. And these are the sort of glucose patterns that we see after a mixed meal test. And so in the dark line, I can't really point out, is the hypoglycemic pattern that happens after surgery. Then you have the grayish line, which is your control, and then the dotted line are the ones who are asymptomatic. So you can see there that you first have your spike after eating, which then comes down, whereas with the controls, the spike is not as large. And this one shows you exactly as I've mentioned before, the sort of response for insulin, GLP-1 levels, and the glucose absorption. So again, if you look at the patients who've had bariatric surgery but are asymptomatic, the ones who are symptomatic and the normal controls, you can see that the insulin levels are much higher. In the patients that have had bariatric surgery and are experiencing the hypoglycemia, and the glucose absorption is also much higher, the peaks are higher, and your GLP-1 levels are also higher. So if you concentrate, sorry I can't point, but the dark lines. Then So should we do a prolonged inpatient fast? And this is a multiple choice question. Is it for all patients that present with post-bariatric hypoglycemia with typical symptoms? Is it patients who have just fasting hypoglycemia? Should we do it for patients who've had hypoglycemia early after surgery within 6 to 12 months? Should never do it, or is it B and C? And the clear answer is for those, we reserve inpatient fasting to rule out insulinoma, particularly the ones who present with these atypical symptom patterns. So if you've got fasting hypoglycemia, that is not usually a feature of post-bariatric hypoglycemia. Right, so what about imaging then? Should we consider imaging for every patient that presents to us with hypoglycemia? Rarely, you would consider it if the patient, like I said earlier, is presenting with a fasting hypoglycemia and other atypical clinical features, or their response to therapy is limited. Imaging for insulinoma can be quite challenging. You might have to do an MRI or an endoscopic ultrasound. Very rarely there may be a need to do some selective arterial calcium stimulation testing as well. Right, so the goals of therapy. Well, we do want to reduce both the frequency and severity of the hypoglycemic episodes because they can be extremely debilitating. I had one of my patients who was a teacher, and it was very embarrassing for her because she would just fall off while she's, in class. And then there was a lot of drama because then, all the kids are going, oh, what's happened to the teacher? And the ambulance comes along. And, she never wanted to go back to teaching. It was very, very frustrating. We want to improve their quality of life as well because they've moved from one situation where they were obese, they've had their surgery thinking that that's taken care of things, and then you come up with a different problem. So what are the interventions? Dietary is the cornerstone. It is the mainstay. And then we can help with some pharmacological agents, usually not as effective as the diet, but patients are not very patient about that either. And then there's some non-pharmacological interventions that can be used for very severe cases. So medical nutrition therapy, as I've said, is really the mainstay. Patients need to be taught how to eat again. So they've got to be avoiding the simple carbs, mixed meals are better, and to use carbs with low glycemic index. And then again here, I'll show you on the my left-hand side, the standard diet, and you can see these glycemic variations, and Professor Ajahn talked about the glycemic variability that we don't want because that also has a risk for complications. And then with a controlled carbohydrate diet, you have a smoothing of the glycemic excursion. So this by far is the thing that works in post-bariatric hypoglycemia. Then this is just a sort of, again, emphasizing the nutritional plan. But at times, with all your best intentions and working closely with the dietitians, it might not be sufficient, and therefore we might have to resort to using some medications. The first one that has really been thought to be very successful, and it worked in my patient, the teacher that I just told you about, is acarbose. It's a disaccharide-dase inhibitor, which slows the absorption of carbohydrate in the gut, and therefore it reduces the postprandial glucose spikes, and therefore reduces the stimulus for insulin secretion. The only thing it's limited by is the flatulence that patients might experience. They might have to take very large doses of acarbose to actually get this effect. And then you may improve the efficacy if it's taken 15 minutes before they actually start taking their food. And here again, I show you the sort of glucose peaks. So in the dark lines are the patients with acarbose, and then the dash lines, dotted dash lines are the ones without the acarbose. And then you can see there again, your glucose levels are much lower with acarbose. The insulin levels also are lower with the acarbose, and then your GLP-1 levels also, there's blunting of that spike with the use of acarbose. If acarbose, doesn't work, you can use octreotide and pasireotide. We've heard a lot about pasireotide today in the context of acromegaly and in Cushing's. So one of the side effects of pasireotide is hyperglycemia. So you may use that side effect profile of that drug to reduce both the incretin and insulin secretion. These can be taken either subcutaneously or intramuscularly. Usually start with low doses before the start of the meal. However, patients may be limited to taking these drugs because of the other side effect of diarrhea. And occasionally, there may be worsening of the hypoglycemia immediately after taking the injection, possibly because of the inhibition of glucagon secretion. So what's after octreotide? You might want to consider diazoxide, because that also reduces the insulin secretion. But again, patients may experience some bloating and edema. Other studies have shown that calcium channel blockade with nifedipine might work, verapamil, anticholinergics, metformin, GLP-1 agonist as well. And then when you suggest a GLP-1 agonist, you think, well, I've been using that to lose weight. How is that now going to help with the hypoglycemia? So here again is just a chart that shows this stepped pharmacology, starting with acarbose. You may consider using diazoxide. We talked about the somatostatin analogs, octreotide or pasireotide. And then there's some authors that have, or clinicians that have also tried the calcium channel blockers and liraglutide. So what about the non-pharmacological measures? So you've done the diet, you've done the drugs, and still the patient is complaining of these hypoglycemic episodes. One might have to resort to putting in a G tube into the remnant stomach, and maybe you might consider to reverse the bypass if that is feasible. However, pancreatectomy is not a solution, whether partial or total, because it's not really curative, and I showed you earlier that it's not an anatomic problem, it's a functional problem. So here's the sort of the G tube. It can be given continuously overnight. There may be different formulas used. It avoids the carbohydrate ingestion orally. But of course, patients, the quality of life of the patient is then, I can't really taste the food. What's the point of life if I can't enjoy what I'm eating? Right, the Ali really tasted good. So just to show you again that, how does the G tube work? It does, as you can see, the dashed lines are with the G tube. So your glucose excursion is lower, the insulin levels are lower, GLP-1 and GIP levels are also reduced when you're giving it through the G tube, as opposed to the higher spikes when you're giving the patient their food orally. Right, if that doesn't work, what would be the next step? You might have to consider reversing the procedure, and we've had a number of patients in our center that have actually had to have, they were so tired and so frustrated with having these recurrent hypoglycemic events that they resorted to reversing the procedure. Other strategies, of course, are very sort of simple clinical things. You're making sure that the patient is safe. So if they're driving, they've got to know that they're not having a hypoglycemic event before they drive. We've offered many patients the CGM. At least it kind of helps them to monitor their glucose levels. Making sure that they've got a glucagon kit handy with them and they know how to use it, or at least the family member around them knows how to use it. A medical ID bracelet also helps, and making sure that they've also corrected all their nutrient deficiencies, B12, iron, all the minerals are all sorted and in good levels. So this is just a summary of the therapeutic approaches. Monitoring is also is important. The dietary modification is the cornerstone of treatment. We can use some of the drugs that I've mentioned earlier, and then if they are refractory to all that, we might have to consider using either a gastrostomy tube or go ahead and reverse the procedure. So we have a lot of unanswered questions. Of course, the field it is an iatrogenic problem, but we don't know about the genetic risk factors for post-bariatric hypoglycemia. Is the syndrome caused primarily by just incretin hypersecretion? Can we therapeutically block, therefore, the GLP-1 action to improve hypoglycemia? These are all questions that we don't know much about yet. Can we identify other systemic factors that are contributing to this hypoglycemia? Are there alterations in energy expenditure, for instance? What about the role of this beta cell hyperresponsiveness? And is there islet gene expression that is altered in patients post-bariatrically? So to finish off then, I will summarize by saying that it can be a very life-altering situation for a subset of the patients that we see. Dietary measures are by far the most successful, followed by pharmacotherapy and 5% success with the procedures. So given the chronic nature and the sequelae of both the acute and recurrent episodes, increasing provider awareness of both the condition and the associated risk factors is critical for both the assessment, the diagnosis, treatment, and the perioperative identification of individuals that are at risk. And with that, I think I'll stop there. Thank you for your attention. I look forward to your questions.